A 32-year-old male presented with poorly controlled epilepsy. I am showing you an axial brain CT and an axial T2 weighted brain MRI. Describe the findings.
All right, let's take a look. The axial non-contrast brain CT shows multiple small calcified nodules located in the subependymal region of the lateral ventricles. The axial T2 weighted MRI confirms several small subependymal nodules which show marked low signal intensity corresponding to the calcifications. Additionally, there are abnormal widened gyri with altered signal intensity involving the left parietal and right frontal lobes. These focal areas of cortical expansion are characteristic of cortical tubers. There is no surrounding vasogenic edema or signs of ventricular enlargement on these images.
I'm showing you an axial brain T2 weighted MRI from a different patient. What does it demonstrate, and what is the diagnosis?
The comparison T2 weighted MRI demonstrates multiple subependymal nodules that have not yet calcified. Instead of showing low signal, they appear as intermediate to high signal nodules that produce a classic wavy or bumpy border to the lateral ventricle walls. These findings are diagnostic of tuberous sclerosis, which is also known as Bournville's disease. The classical clinical triad consists of mental retardation, seizures, and adenoma sebaceum.
Discuss the central nervous system manifestations of tuberous sclerosis in detail.
Intracranial features include subependymal hamartomas, which are most commonly found along the ventricular surface of the caudate nucleus. Cortical tubers are developmental gyral abnormalities that are usually multiple and calcify in 50% of patients. Heterotopic gray matter islands are also common, appearing as focal regions of gray matter density within the cerebral white matter. Most importantly, subependymal giant cell astrocytomas can develop near the foramen of Monro. These benign but expanding tumors can obstruct the pathways of cerebrospinal fluid, causing obstructive hydrocephalus.
Explain the multisystem manifestations of this condition across other organ systems.
Multisystem manifestations include renal angiomyolopomas, cysts, and a significantly increased risk of renal cell carcinoma. Pulmonary involvement is characterized by lymphangioliomyomatosis-like changes presenting as thin-walled lung cysts predisposing to spontaneous pneumothorax. Cardiac findings include multiple rhabdomyomas, which are benign striated muscle tumors that typically regress over time. Cutaneous signs are common, including facial angiofibromas or adenoma sebaceum, shagreen patches, ash-leaf macules, and subungual fibromas.
How do you radiologically differentiate a subependymal nodule from a giant cell astrocytoma, and how would you manage this patient as a radiologist?
Subependymal nodules are small and show minimal enhancement on MRI, whereas giant cell astrocytomas are larger, located at the foramen of Monro, and show intense, uniform enhancement. As a radiologist, I would recommend a dedicated brain MRI with gadolinium to assess for foramen of Monro obstruction or progressive tumor growth. I would also recommend renal ultrasound to monitor for angiomyolipoma expansion and screen for renal cell carcinoma. Finally, I would recommend referral to a multidisciplinary neurocutaneous clinic involving neurology, nephrology, and genetics for coordinated management.